Hello, everyone. There is no peace for the weary. We need to move on because we have a crowded schedule. It's not easy to be the last panel of the day, but it also, when you go to fill out your race, ethnicity, particularly for race, you go white and black, Native American, and then maybe you're multi-race, and you have to check other. And that's kind of how I feel. We're other. And actually, I think that's exciting. Some of the panel members work in the universal area schools and early childhood education, but also really some of the others that are often not talked about in behavioral health, but many of us work in child welfare, foster care, and juvenile justice. So I'm really excited that we have this great panel. And I'd like to briefly introduce the panelists. To my left, Mark Chaffin from Georgia State University, whose research has been mainly on the development, adaptation, and it says here implantation, which usually I think of implementation, but you meant implantation, or did you do?
That could have been autocorrect.
Oh, yeah. Implementation of evidence-based services in the child welfare, juvenile justice, and early childhood developmental disability systems. Bernadette Melnyk from Ohio State University, who's Associate Vice President for Health Promotion, University Chief Wellness Officer, and her spare time, she's the Dean of the College of Nursing. And she's a nationally and internationally recognized expert in evidence-based practice, intervention research, child and adolescent mental health, and health and wellness. Kris Perry is Executive Director of the First 5-Year Fund, a national thought leader on early childhood education, and has dedicated her career to bringing resources and support to parents and caregivers and all the folks that create the context for children. And last but surely not least, Olga Acosta Price, who is associated with George Washington University, actually is an associate professor at George Washington University, and is the director of the Center for Health and Healthcare in Schools, a national resource center for building effective school programs. And we're short in time, so I'm going to ask each of you to spend no more than 3 minutes saying a little bit about your work and the innovations in your work. You push here.
There we go. Good afternoon. I'm going to talk a little bit about scaling up evidence-based practice models, particularly in child welfare systems. These are interesting little service systems that deliver quite a lot of services to children and families. So about 600,000 new cases every year come in. Most of the children in these systems are under 1 year of age or are preschoolers, and then it tapers off as they get older. These are systems that have developed largely because they're outside of traditional mental health services systems. There is no diagnosis, there is no billing code, there is no Medicaid reimbursement. Now for children in foster care, they typically, foster care is a gateway into traditional mental health services systems, and they're often served in those systems. That's less than 20% of the cases in child welfare. The other 80% are children who are served with their families. and for whom child neglect, often recurrent neglect, really is the problem, especially as we've seen physical abuse and sexual abuse in this country plummet by over 50 or 60% in the last 20 years. So neglect has become really the dominant problem in these systems. So these services are often delivered by paraprofessional home visitors, much like the McV services that are preventative in nature that are part of ACA. But they're purchased by child welfare. They're not delivered by the agency or its employees itself, but they're purchased from networks of community-based organizations, much like other systems like juvenile justice will purchase these services from these systems. And what we have found, and what a lot of people have found, is that this really is an exquisite foundation for implementing evidence-based practices that can be informative for what we do in other sectors. These systems use their power of purchasing to essentially purchase network-wide, system-wide model implementations and scale them up and build in and pay for quality control and training and retraining of staff in these systems over time. So they're informative in many ways. They're developmental. They're two-generational. So the services embrace many of the things we've been talking about here today that are, version 3.0 type services. The system itself is absolutely solidly a version 1.0 service. It is episodic. It is reactive. You have to be reported and get into the system in order to get the services. And once the services are done, and the movement is to make these services far more concise, once they're done, and you are on your own. And there is very little in the way of follow-up. And yet these are predominantly, as the face of child welfare is changing, predominantly ongoing, developmental, or in some ways chronic types of problems. So we have growingly a mismatch between the problem we're trying to deal with and the episodic reactive nature of the service system that we've built to deal with it.
I have spent most of my career developing and testing interventions to improve mental health outcomes in children, teens, and their families. Then trying to figure out, once we have the evidence-based intervention, how are we going to get it implemented? We have an old saying, it takes 17 years to translate findings from research into clinical practice to improve care. If you don't believe that, I'm living proof today. It took me 25 years, 9 randomized controlled trials, and not until I showed what I call a so what hard outcome that the current healthcare system is concerned about did anybody start using my evidence-based program for parents of premature babies. We had showed that it decreased parent stress, post-traumatic stress, improved baby outcomes through 3 years of age, but nobody was implementing it until I showed it reduced length of stay in the NICU. And then everybody started calling me and saying, would you come and teach us how to implement COPE? So then I'm an adolescent specialist, both a PMP and a psychiatric mental health nurse practitioner. So I wanted to move my work back to adolescents in a preventive way in the schools. And I thought what we are missing in all our healthy lifestyle programs for overweight and obesity is a strong mental health component, because my research was showing if a teen was depressed, if they were anxious, they're not going to engage in healthy lifestyle behaviors. So I created a 15-session cognitive behaviors skills building program to be implemented in the schools. And I said, we got to look at other providers aside from psychiatrists and psych nurse practitioners who can deliver CBT-based interventions, because we know they work, but hardly any kids get them. So we just finished an RCT with 780 teenagers in 11 high schools, showing teachers can't teach this into their health courses. And not only do we get improvements in healthy lifestyle behaviors, but also in depression, social skills, and academic performance. Now we've taken the CBT 7 sessions out. They're in primary care. We've trained almost 300 providers to deliver this, and they're getting reimbursement for it in primary care. So again, researchers' dream come to fruition. It actually can happen.
Hi, I'm with you on the 50th anniversary of Head Start. And in fact, headed over there to celebrate tonight with so many alumni and others that have been delivering Head Start services across the country for half a century. And I bring that up because I want to benchmark what's going on in early childhood back to 50, 60 years ago, when a couple of very high quality programs were opened up in the Midwest, the Abecedarian Project and Perry Preschool, which were later studied by Nobel laureate James Heckman at the University of Chicago, where he learned that those children, this is a very small sample, but those children who were in high quality early learning programs for 1 year or more had terrific outcomes across their entire life. Everything from higher earnings to better health outcomes, and also they were diverted from expensive social programs like special ed or juvenile justice. And that research was memorialized in a book called Neurons to Neighborhoods that oh, you're all nodding. This is terrific. That really, frankly, brought lay people into this world of early childhood research, brain development, et cetera. And since that point in time, which was in the mid-90s, there was a summit the Clintons hosted at the White House in 1995. A year after that, we saw welfare reform in 1996. And ever since then, there has been a growing movement around early childhood that encompasses Head Start and Early Head Start, but so many other good programs. And the First 5 Years Fund is supported by 8 national foundations that have tried for 20 or 30 years to find the best practices in early childhood. By the way, a best practice includes educational and health services to both the child and the family. It's frankly a model for all kinds of good integration in all kinds of systems. I am a social worker. I'm not a health provider, so I say this to you not knowing what that really requires. But I do know that the Head Start program, early Head Start programs are a model for how to bring families into the child's whole development. And the funders of First 5 Years Fund have been trying for the last 8 years, since 2007, to influence the funding delivered to states through the federal government to increase it dramatically. The unfortunate thing is we know that it makes kids, it prepares them for school and life, but we are leaving literally millions of children out of the Head Start program because we're not funding it adequately. All of the early Head Start funding at the federal level goes through HHS, so interestingly enough, it's not coming out of DOE. DOE only has about $500 million a year that they deliver to states in preschool development grants, which is terrific, but almost all of the federal funding for early learning goes through HHS. So what I was hoping to sort of spur here with all of you in the health profession was to think of early childhood as a point in time to deliver more of the services you care about: nutrition, education, immunization, those sorts of things that really parents need to know. And the early childhood educator is the perfect person to deliver that information to parents through whether they're a small family daycare provider or they're a Head Start teacher or they're part of the K-12 system. Just don't forget that they are receiving federal funds or other subsidies. They're part of bigger systems, and they're really, really terrific at connecting to the child and the parent at the same time. And it's all based on those early studies that were started 50 years ago. I mean, the ultimate randomized control trial and the way that those programs have influenced programs that are being started all over the place now is really significant. And I'm really happy to be here and have you think about early childhood educators and that system as one that could do a lot to increase the outcomes on health and later in their lives.
Hi there, I'm Olga Acosta. I'm a clinical psychologist by training, and but really consider myself a public health professional, and really look at the world through that lens. I was the founding director of the school mental health program in the District of Columbia, so I do have some sort of boots on the ground credentials, I guess you would say, in terms of training individuals who were really great clinicians and had great traditional child mental health training, but had never worked officially in a school and didn't understand school settings and didn't understand how that would be different and what we would need to do in order to sort of really maximize learning and health. But where I am now at the George Washington University is that I direct the Center for Health and Healthcare in Schools. Our aim at the center is really to maximize child development and learning by trying to bridge public health and health in general, really looking at physical, oral, and behavioral health in its entirety, health care, and education. So by being a resource and a policy center that really supports the implementation of what are known effective programs, practices, and policies. We really consider ourselves, and the way I sort of think about us is as brokers and as intermediaries, as we've been talking. I think that we do need to think about the ways that we can each in our roles be stronger, play stronger roles in that regard, because we do know that there are really great, there's really good research, there are great evidence-based practices and programs. What we do know less of, or those who we're hoping will make those shifts in their practice, is that they often can't or they aren't able to make use of the really good evidence. And so there's a really important need for folks to step into that space. And I think there's some really great centers and organizations around the country that do that in individuals. We hope to decrease sort of what I would consider the cultural divide between education and health. These really are systems that are not designed similarly, that have very different drivers, that have very different funding, and we know that at some level, but still often for living in the health side, do try to push how we organize health into schools and then get upset when schools don't feel that welcoming of us. And we try to, as I said, do that translation so that it's in practice. It's very fortuitous that I followed Kris, actually, because I will say that I have been saying, at least in the last 5 years, that those of us who really advocate for good, strong school health policies and programs need to be looking to early childhood programs and early Head Start and Head Start, because the model you have for integrated health and education and including families is ideal. I mean, it is wonderful. I don't feel that we often look at early Head Start or early childhood systems and think that they are an entity with the four walls where we have captive audiences of small kids. We think of them as really dynamic systems, as places where there's opportunities to sort of for multi sort of level interventions. But often when you sort of talk to individuals, and none of you, but when we talk to individuals outside of this room, they often see schools as just walls that have a captive audience of kids where we can do our programming. And I think that it's a really missed opportunity. We are interested in school-connected approaches, not just focused on treatment and good school sort of based treatment delivery models, but also on early intervention and universal prevention. We want to think about how to mitigate risk and think about how we do that in partnership with schools, but also, as has been said a little bit earlier, we really advocate also for promoting activities that promote health and building social emotional development and looking at the kinds of infrastructure changes that are needed in order for us, for example, the use of surveillance and data systems so that we actually track indicators of well-being that are actually about well-being and not about preventing negative outcomes. And if you think about how we define well-being, and there are a number of places that have indexes of well-being and indicators of well-being, but you actually look to see what those measures and those metrics are, they're often about the reduction of a negative outcome or the sort of the elimination of, pick the negative outcome and place it in the box. We often don't think about school settings as important stakeholders of health and healthcare as healthcare providers, but really for particularly segments of our population, and I'm going to adolescents in particular, schools really are the primary providers for behavioral health and physical health care, both through school hired providers, school nurses, as John very eloquent talked about school-based health centers and the benefits of school-based health centers, what we call standalone or expanded school mental health models, and through other partnerships like communities and schools models. But I also want to talk about the benefits of thinking about universal prevention in schools and things like school climate and positive, providing positive environments in schools, and the robust body of literature that indicates that there's a real significant link between positive school climates and increases in students' attendance, engagement in school, decrease in conduct problems, so on and so forth. What I really want to say is that educators are really understanding, Shep, I feel like, Dr. Kellum, that although you were never a teacher of mine, I am philosophically and in spirit, I am your student, because every time you spoke, it was like, yes, 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 everything he said and more. And I want to say that many more educators really understand that health and educational performance are inextricably linked. I don't think we don't have to make that case as much anymore. They recognize that for students to meet academic standards, they have to have a concurrent focus on teaching quality, but also on healthy school environments and on promoting individual child competencies and strengths, and also thinking about the adults and how the adults in the environment play a very big role in how young people's health and well-being.
Thank you, Olga.
Yes, absolutely.
Thank you. That's terrific. So we're asking every panel to think about the Affordable Care Act and healthcare reform more widely, and consider what are the greatest opportunities from your vantage points, from each of your vantage points, for preventing risks, for intervening, promoting mental health in children and families. I would like to add a couple of other items that I want you to think about. One is, how do we train a workforce for the 21st century? And what are the risks in your field, not only for benefits, but also for adverse events, adverse outcomes?
I'll talk about some of the possible opportunities that ACA offers. It doesn't offer all that much for children in foster care. They've been covered forever. And it doesn't offer all that much in some ways for other populations of children in child welfare. It offers a great deal for their parents, which indirectly, or actually probably more directly, offers a great deal for children. Child maltreatment does not occur in a vacuum. It occurs predominantly in a context of dire poverty. Last trial I was involved in, the median family income of our families and services was $900 a month. Now stop and think about that a little bit, about what your life might be like on $900 a month, and if you had 2 or 3 kids. So primarily, I think largely the way we help kids in these systems through ACA is by helping parents. And there's 2 or 3 problems other than poverty is one. Your odds of entering child welfare, the odds ratio for entering child welfare if you're below the poverty line is not 10 or 20, it's 44 compared to the median family. An odds ratio of 44, now it's kind of hard to wash that out with any kind of third variables or confounders, however you put them in the model. But poverty is a big one. The other one is substance abuse, and potentially greater access to substance abuse services, which are not something that are delivered directly within these systems because they have too long of a time frame for recovery, monitoring, and maintenance. And the third one is probably parental depression, which has done a lot of work on, and others as well. So I think access to these types of services for parents and families is probably one of the biggest opportunities under ACA to improve the long-term development of kids in these systems.
The Affordable Care Act is reimbursing now for A and B recommendations from the United States Preventive Services Task Force. I served on that task force for 4 years and chaired the child task force under that umbrella. And I will tell you, we do not have a lot of child health evidence-based recommendations that are not an I, and that is insufficient evidence. So we would take a lot of heat, those of us on the task force, by saying, why are you always putting out these I recommendations for children and teens? In fact, when topics came to the table, and it was a child health topic, because I kept bringing screening for behavioral and mental health problems in young children to the table, the task force voted it as a priority, but we still have yet to see it because people were hesitant. They're saying, but Bern, we don't have enough evidence to answer that systematic review. There just isn't. And if we keep putting out I statements, we're going to get people more frustrated. But here's my answer. I statements should drive federal funding from NIH, from HRQ, because we're saying we have insufficient evidence. But if you look at the amount of funding from NIH and HRQ for child problems, particularly mental health issues, it's abysmal. So we have to push that more. And lastly, we have an issue with we can't expect, just because we disseminate an evidence-based guideline or recommendation to providers, they're going to implement it, because that's not happening. Providers, many providers are still steeped in, that's the way we do it here, that's the way we've always done that. And finally, one last comment. We can't expect our kids to engage in healthy lifestyle behaviors, including mental health, coping skills, unless we do it ourselves. We have to role model that. We have to establish cultures and environments that make healthy behaviors the easy choices to make.
I'd like to highlight the one thing that you said, because a very specific recommendation that these insufficient evidence interventions in areas where there are very, very few options are an opportunity for the NIH and others to fund. The need is there. Kris, I'm sorry.
I think you should all be prescribing reading, literally. You should write a prescription for reading. And it's a really easy thing to scale in the workforce. I think you could send out a memo that just says prescribe reading. And I'm being overly simplistic because it's so obvious, but no one's doing this. Very few physicians, very few health providers are doing this. I know how precious your time is during those well-child checks and home visits. I get it. And I think if you are doing it, congratulations. And if you could just tell your colleagues to do the same thing. Children in poverty are exposed to 30 million fewer words by the time they turn 5. It is absolutely the biggest contributor to the achievement gap, and one that really can't be resolved once they hit kindergarten. It needs to be addressed very, very early on. And parents, with all of the pressures on them, I think it's a fairly simple and straightforward recommendation. And they can do it through talking and singing. They don't only have to read. I know some parents struggle with that too. So you want to prescribe the exposure to language to increase not only the child's brain growth and stimulate brain growth, but the attachment between the caregiver and the child is everything. It will allow them to attach to other caregivers later on. teachers, bosses, grandparents, anybody. This is the glue for the child's synaptic connections, but also their community and family connections later on. So my plea with all of you, with your commitment to human development and child checks and well-being, is that reading, talking, singing, brain development is part of what you're telling parents when they're in your offices or they're in your clinics, or it's up on the walls and you're demonstrating it for them. Because if they get handed over to a kindergarten teacher at 60 months of age and that hasn't been happening, she or he cannot repair that. And they can start trying, but it will never work as well as if you made the intervention. Every focus group, every poll, everything we've ever done shows that the most likely, the most successful messenger on this is the physician or the nurse. So you are in a very unique and powerful position to influence how parents interact with their children around literacy and learning.
So I would say, I think maybe 4 quick opportunities. First, I would say in terms of health care and payment for healthcare services offered in schools, we advocates in the school health world have been and should be jumping up and down about in celebration around the guidance around the free care rule. It was mentioned a little bit earlier, but I just want to spend another moment on it because I see somebody said, what is that? So the free care rule in Medicaid is a regulation that says you can't pay for services, they will not pay for services that are offered to the general public without charge. So for those who are doing school health services, particularly school-based health centers, school nurses, other school-based providers who are offering those services to everyone regardless of their ability to pay, they weren't allowed, or at least the interpretation of the guidance was, they weren't allowed to actually bill for those eligible services for eligible kids if not everybody who received that service was billed to their either private provider or to just, if you have no insurance, to your parent, to be billed. In December, Cindy Mann actually sent a guidance to all the state Medicaid directors that basically said that to clarify that Medicaid reimbursement is allowed for covered services under approved state Medicaid plans that are provided to Medicaid beneficiaries, regardless of whether there is any charge to the community at large. Big win. Big win, like very exciting for those in doing school-based health services, school mental health, school nursing. Although the federal barrier is eliminated, or apparently so, the battle isn't won because the free care rule and its removal as an impediment for obtaining reimbursement is gone, but that we still have no real guidance, and I'm sorry for the person who hated guidance, and I'll say guidance small g, that about how states and school districts are actually going to implement the rule and what's going to happen with state Medicaid and how they will actually make changes that may be regulation changes that have to happen at the state level in order to really see that lever, that funding lever shift and for that to be allowed. So again, the idea that governance, that guidance around that is necessary in order, because these Medicaid plans really do vary state by state, this technical assistance is needed. Another one that was alluded to, but I just want to highlight again, is the changing regulations around the types of providers that can be reimbursed for preventative services, and again, the community health workers, allowing states greater discretion over non-traditional providers who do prevention in non-clinical settings. Again, think about schools in that regard. This has particular implications for communities of color, and we did a body of work that really was about looking at communities with high-density immigrant and refugee families, and one of the things that they told us over and over again, and these were families who had significant trauma, and where that intergenerational trauma was playing out and the effects of that, is that they were not able or willing to really address their mental health challenges. And of course, we didn't talk about it as mental health, and that's a whole nother issue around cultural responsiveness and competence. But because these challenges don't occur in isolation of other daily stressors and a culture of distress, that it could only happen if we embed it in comprehensive services, so that according to them, the basic needs and their social service needs and their acculturation needs had to be addressed before they were going to be doing any trauma-informed therapy that was appropriate for them. So again, it has to be sort of embedded in a broader thinking. And family liaisons, i.e. cultural brokers, i.e. community health workers, are sort of play a significant role in helping to navigate and understand how to address all of those needs and folks who are trusted in those communities. So that's another one. The other two I'll mention quickly is accountable care organizations. And I'm thrilled to hear about what Dr. Kelleher was talking about, Partners for Kids, and saddened that they're really maybe the only accountable care organization with really children at the focus. I Googled accountable care and children because I wanted to see if anything came up, and nothing came up. So I'm sorry, but we have to work on your system optimization to make sure you guys come up when you Google. But it was, but now I know and it's marked and I'm happy. But the other one is, so again, the opportunities for schools and school health providers to be a part of these developing entities, we're primed to think about that. And yet there has to be a commitment at the local level to do that. Finally, again, this is the part that's hard about going last. Everybody's made these points, so I just get to reiterate them, is about school-based telehealth. Innovative models, growing models of innovation, particularly being utilized in schools to bring primary and mental health care, particularly in shortage areas. This has been used a lot in rural areas, but now growing in urban areas and other areas, linking qualified providers to really increase access to care. But the payment models are really still underdeveloped, and we have a lot to learn around implementation and how to make some real best practices around this, but it is a real important opportunity that ACA.
Thank you. Are there any questions from the floor?
I'm sorry, I have to dash off and catch a tram. Doug Tynan from American Psychological Association. It was a wonderful presentation. There's one clarification point because there's been such an emphasis on early childhood education. And I worked on the committee for the evaluation of Head Start 10 years ago, and we did the Head Start Impact Study, which showed actually very mild improvement from Head Start. So what's the difference between the mild improvement Head Start and things like Abecedarian and Perry Preschool? A lot of people don't know this. Perry Preschool Project was a half-day program for 2 years, but every child got a 90-minute individualized home visit with the teacher working with the parent. Almost all policymakers I know who talk about Perry Preschool do not understand that.
Week, a month?
Every week, 90-minute visit from the teacher. It's in the original documents, and nobody reads the original literature. That's the problem. Abecedarian Project, if you talk to Craig Ramey, he's still working down in Roanoke. He said parents were assigned a parent coach at birth who worked with the family until the child was 5 years old. So 5 years of contact. The other big program is obviously David Old's Nurse Family Partnership, which is all about parent-child. My point is all of the really effective early childhood programs that have these massive positive effects involve a strong parenting component, whereas Bill Clinton once said, families raise kids, not governments.
Can I just respond briefly
Yeah.
to what you just said? The methodology of the impact study stopped, the kids were only in 3rd grade. The other 2 studies that I referenced, those individuals are now in their 50s. And one of the things that we're trying to do when people reference that study is say, we know that the outcomes that were gained from those other programs, and by the way, Head Start does have a family engagement component.
Right, but it's not as intensive as what was in those other studies.
And I don't think Head Start is going to get necessarily the gains
Right.
that the other programs did. And it's an example of how we should improve Head Start to get that
Right.
level of engagement. But I think it's also, there's an attempt to get those results by having a family engagement specialist. But wouldn't it be great to start looking at where Head Start alumni are today? I'm going to go listen to.
I absolutely agree with you on that, but I've seen with the Early Learning Challenge grants in Delaware, 98.5% of the money went to improving preschool, 1.5% of the money went to parenting interventions, because there are people who say it's all about preschool, and it is not.
And I agree with that. It's not.
Okay, thank you.
That's a very important question in implementation in general, that when we scale up, we tend to water down. I know that's happened with the nurse practitioner model, certainly in Florida, that it doesn't have the level of intensity that David Olds meant to. And, you know, it's often we think that if we have enough antibiotics for 10 people if we spread them across 100 people, everyone will get a little bit of benefit. And in fact, they don't. And so this is a misconception in our field that sometimes it's preferable to to address a smaller number of people and do a great job with them and do the program the way it was tested. Yeah.
So enjoyed the panel, and maybe a question for the panel and maybe something to continue tomorrow. One thing I didn't hear throughout today is just to raise and to remind is that Medicaid EPSDT covers kids up to age 21. The ACA affords coverage for kids up to age 26. And I think an important population to be talked about are older adolescents and young adults. I think of issues like pregnant and parenting teens. I think of issues of transition to adult healthcare or mental health systems, which we know are huge issues. I think about issues of kids over 18 and what it means to have mental health services and families involved in that or not. So I just would commend this panel and just raise that maybe that's something else we can be talking about either today or tomorrow.
Just one comment. I don't know if you're aware, but we have a new national organization. It's called the National Consortium for Building Healthy Academic Communities. And it is very, of course, focused on late adolescents, young adults, and the community in which they live in higher education.
Comment, Mark mentioned that some welfare systems are investing in evidence-based programs, and I don't know exactly the number, but I think the Administration for Children and Families in New York City has invested something like $30 to $40 million, is that right, in evidence-based programs?
These systems were fairly late coming to evidence-based practice, but I think at this point the ramp up is clearly underway. And in many ways, there have been full statewide implementations of single evidence-based models or packages of evidence-based models. And this has been going on in a number of states. And partly it's been driven by everybody likes outcomes. But it's also been driven by the fact that the cost-benefit analyses on these essentially shows a short-term recoup of money in lower rates of return to child welfare. Rates of return to child welfare are commonly 50% or higher within the first couple of years. It's high. And some of the evidence-based models have successfully been able to reduce this by, in some cases, as much as half. So that's a substantial reduction that has real cost implications and savings. And so that's driven a lot of these systems to take these models up, including budgeting directly for things like implementation quality, monitoring, ongoing competency development of workforce, and other things like that.
You have a question.
Laura Kwong from SAMHSA. So I read a book in an airport recently that said a good meeting should have jaw-dropping moments. And I think this meeting has had incredible jaw-dropping moments for me. I've learned a lot. I think one of the moments for me that was really critical was in Neil Haffin's slides on the community dashboard. And I think, and then we've kind of gone a lot of different places in this day. And I'm wondering about this concept of integrated care. We've talked about it in each of the panels, and we can look at it through the medical healthcare system, where we think about integrated care at a clinical level or a program level with primary care and behavioral health coming together. What I loved about this panel is that we're really widening what we think about integrated care. That really for kids are not in just one or two systems, they are in their families. So I think as the committee goes forward, I'm concerned that if we think only of integrated care in the locus of the healthcare system, as we know it, that we're going to miss all of those things that were on the community dashboard and the community health indicators. So for example, if we're looking just at the mental health care for a kid to be school ready, what about the school being ready for these kids that are not ready for school? So that the indicators should also be measuring the entities or the systems that their kids are in. So I guess that's one question I had about the mismatch then between how we think about different levels of integrated care and what the funding mechanisms, whether they're out of ACA or other federal or state government mechanisms, because the pediatricians, the providers, all of you doing you boots on the ground people, I think that's a pretty cool term. I don't know what I might be then. Heels in the clouds or something, but so what does it mean? Because I've heard so many effective, strong programs and practices, but our kids aren't necessarily looking better on some of the key indicators that we measure in the federal government. So where do we go? How do we begin to put all this together? How do we begin to match our delivery reform and payment strategies to what we're talking about as these practices that are integrating way beyond just I think to just integrate primary care and behavioral health, we're not going to hit all those other social determinants.
Thank you so much for highlighting how important it is that we think of integrated care well beyond the healthcare system to other systems, schools, the welfare system, the juvenile justice system, as you said, if the child is not ready, then how do we get the school ready to help a child that is not ready? Thank you so much for underlining that. Olga.
Thank you so much, Lark. I think it's a brilliant question. And oh, okay, so I'll make it a quick answer. I think you're absolutely right that, one of the things I get worried about is that for very effective programs, if you've got kids who get to the point where they're at the same starting place as other peers now, so we've moved them, we've reduced that gap, we put them in their host or the host environment, being the school. I mean, the goal is to get them ready for school. School's the receiving environment. Isn't ready to then continue to support that development in the ways that they have in early childhood. We see then the gap comes back by third grade. And so you're absolutely right. We need to think about those systems. One piece of that is with the funding. Again, it's a sliver of maybe the beginning of the answer is prevention and thinking about the fact that educators, again, who increasingly agree that we can't just educate the kid in this core syllabus and not think about the whole child, but my hands are tied because I only have education funds. I only get Title I or Title II or whatever it is, and so I can't use it for health-related things, even though I know that that's what I need to do. So we took that on and said, we don't think that's actually maybe accurate. It may be a myth in how federal education funds can be used. And we did an analysis of the 15 biggest ESEA-funded programs that we hope will continue to be funded, and said, looking at the statute and doing an actual analysis of that something like 12 or 13 of the 15 explicitly allow for those federal education dollars to be used for health prevention related activities, as long as you make the case for how it's connected to the aim of the provision. And we can all do that. We have our local data. We know how these things are connected. And so it was a matter of saying you actually can. Now, that's the information, the will to change, and now to say, okay, so now I know I'm allowed to do it. That's a whole other issue, and that's where advocacy and coalition building and the other things that happen that are important have to come into play. But I think it's one piece of it is those dollars which come into schools pretty regularly can be used for the kinds of whole school or even targeted interventions that we're talking about.
Please join me in giving this.